Okay, we'd like to talk a little bit about the head injury. I think I was just ending on the last video. So the Monroe-Kelly doctrine, again, we talked about in the past, finite space, you encroach upon that space and you cause the brain to be displaced, causing herniation. And this is what we're going to be looking for, this increase intracranial pressure causing some type of herniation going on. This can be caused by multitudes of types of injuries. The ones that we're going to be looking at are usually cerebral contusions, which may or not have a lot of bleeding going on. This is a result of our rear-ending type accidents or contra coup type injuries. Whereas the head moves forward, the cerebrum moves in a retrograde fashion in the posterior skull cap as the cranium reverts backwards. The cerebrum moves forward, causing this contra coup type injury. Now, what we need to know is that there are layers: the epidural, and the dura, and so between this epidural and dura, we get potential bleeding. Between the dura mater and the skull cap, bleeding can happen between there. That's on top of the dura or the epidural, and that will cause bleeding and compress on the brain. Usually, this type of bleeding is fast. This is arterial. There may be a point of lucidity where the patient goes unconscious, regain consciousness, then goes unconscious again, or had some altered mental status, became lucid, and then became unconscious or altered again. Again, this puts pressure and displaces, and the Monroe-Kelly doctrine again comes into play. Below that would be a subdural bleed. Somewhere below the dura causes is bleeding, and this is less arterial and more venous, and this will cause more compression. There are different stages of subdural hematomas: acute, subchronic, and then chronic type bleeding. And then we're always looking for an increase in intracranial pressure signs, and that would lead us to widening pulse pressure, bradycardia, irregular breathing pattern. You guys can tell me what that is. All right, so we're going to move over and finish up a little bit more of our head injuries. So when the injury occurs in the cranial vault and it pushes on the brain matter, it compresses just not only the brain matter but the nerves and the blood vessels and the spinal fluid. And what happens is that the brain needs to have this perfusion. And so what happens is that the body tends to increase by causing the heart rate to slow down, increasing the amount of blood volume being pushed up into the brain. And the brain then senses the amount of blood flow. This is that cerebral perfusion pressure. And so as the mean arterial pressure from the blood pressure going up has to fight its way against all that pressure pushing back, it's an increased intracranial pressure. That extra blood, that blood that makes it through, is whatever is the blood that perfuses the brain, or called our cerebral perfusion pressure. What we worry about is this type of herniation that causes compression of the spinal cord against the cranial nerves. Now that would be a tentorial herniation. Another type of herniation is uncal herniation, where it's a lateral compression, where the brainstem is pushed this way laterally versus inferiorly. Now remember, we got to monitor our patients' end-tidal CO2 and gauge this, because what we don't want to do is overbreed for them and wipe out the CO2. If we wipe out the CO2 and we increase the oxygenation because of arterial, this will increase causing more pressure in the brain. And so we want to maintain our end-tidal CO2 between. All right. So there is some permissive hypercapnia that we are looking at. Now, I know I've told you in the past that when we are breathing for patients, we want to breathe at their normal intrinsic or their physiologically intrinsic rate based on their condition. So pathologically, if they're a DKA patient, their respiratory rate is, and so we should be breathing for them quicker. We should be hyperventilating for them so they can off-gas some of the byproducts of gluconeogenesis. In the case of the head injury, we'll see breathing patterns change. They can be hypoventilating or bradypnea, less than 12 breaths per minute. They can be fast or tachypnic, greater than 20. They can have neurologic hyperventilation. There's this deep and fast. They may also have chain stoking, where we have this crescendoing, increasing in respiratory depth and rate, and slowing down in breath depth and stopping and slowing in rate. Biots is even slower and more irregular, and they're very hypoventilating. And then ataxia, which is less than 8 breaths per minute, or agonal, which is less than 8 breaths per minute. Ataxia has just no rhythm at all and is very slow. These slower breathing patterns are going to require us to breathe for them a little quicker. What's happening is that the brain is recognizing that there's a lot of pressure up there, and so it's trying to slow its breathing down. It's also noticing that there are oxygen deprivation, and during those certain points in time that the body will start to increase its respiratory rate. Nevertheless, remember, it's pushing down on the brainstem, and when it's pushing down on the brainstem, we have our respiratory drive centers, or our respiratory tuning centers, and their apneustic and pneumotaxis centers, that, and as well as our vagus nerve. So think about that as we move on down, and how it can dramatically make our patients worse. All right, take into account those things. I want you guys to think about restraints that patients may be using prior to getting this kind of head and neck injury. I want you to think about the seat belts, helmets, and helmet removals. And this includes not just motorcycles, but to all sporting events where they have cages over the face areas, and how we're going to take those apart. A lot of times, the cage does not come with quick release, and it doesn't have the special type of tools that you need to take the face mask off in order to manage and take care of the patient's airway, or to evaluate the patient's injuries. I want you to start to think about those types of situations before you respond to those types of calls.